So I will be talking about peritoneal metastasis in metastatic gastric cancer. Why is this such an important topic? So metastatic gastric cancer can come with mets to multiple parts, of which peritoneal mets are around 15 to 20%. Now these can be diagnosed either at surgery, or you could diagnose them based on your imaging itself, or this could happen in a patient who has been previously operated and now has come back with a relapse. These are the general categories where you would find peritoneal mets. Either it be expected or it would be unexpected. So when you have to incorporate peritoneal therapies in metastatic gastric cancer, I think everybody would agree in a stage 4 disease you cannot do without a systemic therapy. So the question is, along with the systemic therapy, what else can you do? And you have options. You have the HIPEC, which is hyperthermic intraperitoneal chemotherapy. You have something called PIPEC, which is basically you would put a powderized and do it, or you can have a normothermic intraperitoneal. All these are things which are very fond of, which a lot of surgeons especially are fond of, and there is a lot of data on this, a lot of discussion over past few years. Now the most interesting thing when I was reading up on this is all of these studies which have incorporated a systemic versus HIPEC, and in many cases HIPEC, all of them are tested versus nothing extra. You are only having the systemic plus one of these versus really nothing better. And after that, when you start looking at the evidence, there is not so much evidence. So let me tell you why I am saying that. This is a pretty seminal paper that happened in 2012, which is 14 years back. Now in this paper, they included 159 patients who actually underwent a HIPEC over almost 18 years. Now then they found that the median follow-up was 20.4 months, the median survival was 9.2 months. Okay, so this is metastatic disease where HIPEC has been done with a median survival of 9.2 months. The only thing they found is if your PCI, that is the peritoneal index, was low, then it was better, with a better 1, 3 and 5 year survival. Now better in this context means that at 5 year survival was 23%. Okay, so only 23%. The 1 year survival was slightly better at 61%. So this paper actually gave rise to the idea that if your PCI is less than 12, you could think of doing something. Above 12, do not do any surgery. And I think over the past 15 years, this is something that would be pretty much an acceptable modality, that do not go for a local surgery or a peritoneal surgery with high PCI, especially more than 12. Now the one thing which probably no one talks about is in this study, they had a grade 3-4 mortality of 6.5% and a morbidity of 28%. I have this discussion, as all medical oncologists do, with anybody who does this, and they say these are untrained people who didn't know how to do it and we know how to do it. So it's good to be confident and it's nice to meet people who are so confident, but remember this is not always true. So essentially this paper gave rise to the idea that PCI 12 is kind of your borderline cutoff. What are the other studies? Now this I have taken from a paper in 2021. I am not sure how much you can read in this, but essentially what I will point out is the first thing, all these papers came out in 2015 to 2018, when our systemic therapy is actually not great. This is for all patients who had CRS and HIPEC for peritoneal metastasis of gastric origin. So all in that age when you did not have the immunos, you did not have the more modern drugs, I would say. I don't like using the word modern because that's what all radiation oncologists talk about their machines. Chemotherapy is evolution. So that's I think evolving medicines. The second thing to note, look at the numbers, 200, 300, these are the meta-analysis. Individual numbers are actually only 30, 40, 20, those are the numbers that you have. Look at the drugs involved, it's basically a mixture of everything. So essentially mitomycin C, oxali, cis, ito, adria, multiple drugs are used without any one pattern. This is because obviously the trials have been done in different countries. Next, look at the morbidities, and remember this is done by and large by peritoneal surface surgeons, and the morbidities of grade 3-4 are anywhere between 20%, 15 to 20%. A mortality is anywhere between 7 to 10%, and these are real figures from what have been published. This is not anecdotal, this is not experience, this is not my feeling or my wish. This is what is published data. So, when you do a peritonectomy, when you are doing a HIPEC, these numbers are things that we need to remember. Finally, look at these survivals. You started with 9.2 and way down if you see, you are getting a report which says a median OS is 13 months. And then you start reporting things like 5-year OS is 3 times higher and gives you a nice RR saying 3.25 with a big p value. So, 3 times is 3%. So, if you have something which is giving you a 5-year survival of 5% and that goes up to 10 to 12%, it is not a huge number. So, again these numbers should be taken with a pinch of salt and the fact that this is where it is. Ultimately, what we all have to realize is based on the data, in a clear metastatic peritoneal disease, HIPEC is not curative. You can do HIPEC, it is not that I am saying do not do it, but please understand it is not a curative option. Your systemic therapy still has to be there and your HIPEC will help you prolong the PFS maybe, but will not give you the OS, it is not a cure. Therefore, when we counsel a patient and say no, we will remove everything and give you HIPEC, you are not curing, you are prolonging the life, which is fine, there is nothing wrong in that. But we should not be under the misapprehension that HIPEC or CRS is curative, right. So, I told you these are all older numbers.